what I want to do is shift gears again, because we've been talking around this issue a little bit, but I want to talk about payers translating clinical trial results into understanding the appropriate patient type, which is just what you were talking about, for a given drug. So why don't you continue on with that a little bit?
Sure. Well, clinical trials are set up to determine that the drug works in a particular situation. It's not set up to find out what is that situation. And so we have a bit of a disconnect. In other words, it works for the patients in whom the trial was done. But we don't know if those were all the right patients. They didn't test that.
They were pre-selected for this trial.
They're selected for the trial because they clearly have the diagnosis, because they have a certain level of severity, which is measured by things that are hard to measure, but the clinicians in the trial are willing to do it. And also, usually, they have a lack of other problems. They're not taking a lot of other drugs, and so you can tease out the effects of the particular drug, both good and bad. So what happens is that we start with, well, those are the folks that were in the trial. So we know it works for them, so that's kind of the base group of patients that we would allow to have the medication. That doesn't mean that that's all the patients who are going to respond, but now we have to get to, well, what are the other patients adjacent to that? How do we know? Is it okay? It probably would work if they're taking a different medication, as long as it doesn't have some direct effect on, bioavailability or something like that. But is it safe? And that's oftentimes the issue is that you don't always know the safety of drug interactions. So, so the problem is trying to expand beyond the immediate trial population to a reasonable population around it. And that's something that sometimes takes some time. And sometimes we have the data, we understand how the drug works, we understand the drug interactions. Because of that, we may be able to get somewhere. So we look at the clinical trial, who is in it, we look at the efficacy in the trial, and we also really use a lot of the subgroup analysis that comes out of the trial. Who are the patients that really benefit the most? And it might be the patients who are the most severe. It might be the patients of a particular age. And we'll look at all of that, and that will help us to try to make sure that those patients get the drug first.
It occurs to me, I don't know how many times I've heard this. I'd like to give it to Joe or Mary. But gee, they weren't in the study. They were excluded. They were excluded because they had comorbidity A or comorbidity B. So they don't really fit the profile. And if I give this guy or this woman this new medication, because it wasn't typical of the patient in the study, we may not get reimbursed. We may not be within the guidelines set up by the insurers.
Well, and an insurance company may be on the hook for that if they allow an expensive medication to be used in an inappropriate patient because of reinsurance.
But how would you know the patient's inappropriate until you start using it a lot? See the chicken? See the egg?
but who's responsible for that? Is it the insurer to play that role? I would argue it's not.
Or let me be devil's advocate again. Maybe the insurance companies have put themselves there because they're making that decision. They don't want to make it. I mean, as a physician sitting across from a patient with a terrible problem, most physicians will say, I'm going to try anything. I'm going to give you what I need to give you. It's expensive. We're going to send the bill to him.
There it is. Somebody else is paying.
There you go. It's somebody else's money, right? But to some degree, who else is going to do it?
I mean, the reality is we need to do a better job of getting all of the stakeholders together at the same table and addressing the cost, the value, and risk. We don't do that very well in this country, and I'm not going to, right? So right now, the insurer bears the risk, and that's probably inappropriate. So if a drug doesn't work, and the pharma company is not on the hook for that, the provider's not on the hook for that, I would argue the provider doesn't necessarily need to be on the hook for that, but the insurer should not be the only one on the hook for that. So we have to practice evidence-based medicine because we have a set amount of dollars.
Fair enough. But where's the evidence going to come from? In other words, when we're working from here, which is a very narrow slice of patients who've been in a study, right? And we're working our way out to all comers in a larger pool who may or may not benefit, right? Who's paying for that? And how realistic is it to use these narrow studies to try to define who's going to get it, all comers?
The insurers are bearing the cost,
They are.
But increasingly there's a larger shift to the patients bearing the cost. So with these specialty medications, patients are bearing more of that cost, and there are patients who just simply can't afford it. So affordability of these newer medications has to be addressed as well.
Absolutely.
Right, but again, we certainly as a nation, and I don't know how we got on
That's
this
a bigger
track,
issue.
but
That's not
it's
an
a huge issue,
That's not
right?
necessarily just an insurance issue. That's
yeah.
a bigger issue.
Right, people who are rich can get better therapies than people who are
That,
poor.
you
We
know,
don't want to be there
that's
either.
potentially the concern with something like this. If you look at multiple sclerosis, 90% of the cost to treat multiple sclerosis is drug.
Okay.
So where's the ROI on that? Now, I'm not saying we shouldn't treat MS. Absolutely, that makes no sense. But there has to be some, if we're investing these types of dollars in the system, then there has to be a better discussion on who pays for that, and we all need to have a problem. My opinion is we all need to have a piece of that.
And we all need to have a discussion as a nation about this, right? Because you can't be left on the hook for everything.
Like I said, if we're doubling the cost of what we spend on drugs in 3 years, and in 3 more years it doubles again, who's paying for that? Who's going to get stuck with that? It's the patient.
All right, so let's
And that's
come
unfair.
back.
That's unfair.
It is unfair. Unfortunately, that's the way it is at this point, right?
Absolutely.
I want to come back to some...
But we have wonderful technologies that are helping to cure patients and helping to take what was a acute disease and now it's a chronic disease. Look, CML, that was a death sentence 10 years ago. And now people are living, people are functioning parts of society, functioning parts of the workforce. Take MS. We have wonderful therapies now. And even will we be having the same discussion about moderate to severe atopic dermatitis patient population that was not showing up at work or, yeah.
Well,
so,
look, I want to move on, but it is fair to say that the insurance companies bore a lot of the early on expenses for all of these things until they entered mainstream. And when more people got them, we worked out ways to do it. And one would assume that we would do this too. God, he's made me feel bad for insurance companies.
There's a misperception. So I'm here representing payers.
Yeah,
and honestly, we are doing the best we can. We do not want to say no to people. It's our job because we're on the hook for our customers to spend their dollars wisely. And it's a population tool. Okay. So we have to do the best we can. And it's managing around evidence and value and those types of things. And we just, right now, we're unfortunately bearing the brunt of it.